Hello. If you're one of those students who's been trying to understand ECG all their life, but never really could, I can understand because I was one of them. Right? I tried studying it in first year, final year, during internship. I never really got the hang of it. And one of the reasons for that is because most teachers they end up forgetting how they were as a student, right? They end up forgetting how they were, and they end up just taking classes as a matter of factly, and between the lines things just get lost. So if you are a medical student who's struggling to understand what ECG is and have tried a lot, I think you come to the right place. So in today's episode, what we're going to do is we are going to understand a few basics that are needed in order to understand ECG. We'll start with understanding what a pacemaker potential is, what an action potential is, and how the conduction happens inside the heart. And once we're done with these basic components, in the next episode, we'll go to ECG proper, where you'll have a thorough understanding of what the leads are and how to read an ECG. Alright, so I'm Shakthi, and welcome to Physiology with Shakthi. So what we're going to understand today is what a pacemaker potential is and what an action potential is and how different they are in their properties, in their location, right? And this is something that a lot of students don't really understand. So there's something called a pacemaker potential, and there's something called an action potential. Now where they're generated, it's completely different, and the properties are also different. Now you know that a heart has a property of automaticity. It beats on its own. You don't have to do anything, and there is not necessarily a need for a external cue to actually keep it going. Obviously, the sympathetic parasympathetic system modulate it, but you don't really need them to keep it going. So how is this actually happening? That is because of the innate nature of the pacemaker potential. Now what you have to understand is, in the heart, there is the atria, there is also the ventricle, right? And these are myocytes. There are muscle fibers, cardiac muscle fibers present in them, right? And the property of a cardiac muscle is that it acts as a syncytium. The all or none law is applicable to the cardiac muscle as a whole. But when we talk about each syncytia, atria is one syncytia and it is separated from the ventricle. So these act as separate syncytia. So one spread of impulse will be taken together everywhere into the atria so that they contract together. And the spread of impulse goes through the ventricle so that they contract together as a whole. Right? So this happens because my muscle fibers, the cardiac muscle fibers, right, they have gap junctions present in them. So because of these gap junctions, what happens is there is rapid passage of electrical current through them. So that is one thing. The next thing is there are also, at the level of the intercalated disc, there are also presence of desmosomes. So because of them, they are tightly adherent to each other, so that when there is a mechanical force, it is applied throughout the muscle fiber in a sensation. So we have atrial muscle as well as a ventricle muscle. So now these action potentials are actually generated in these muscles, the atrial as well as the ventricle muscles, where the action potentials are generated. Now this action potential is kind of different from what you expect in a muscle fiber. Over here the action potential would be like this. Okay, so you need to understand how we come to get this action potential, and that is through what we call the pacemaker potential. So apart from all this, in the heart we have the SA node, right? We have the AV node, and between them there are interconnecting bundles, anterior, middle, posterior, and there are interatrial connecting bundles as well. After that, after the AV node, it crosses inside the heart, it penetrates inside the heart, right? And it goes down as a bundle of His, which separates into two bundles, right and the left. And further on it becomes the Purkinje fibers. So these tissues that I mentioned, these are modified. These are kind of modified tissue, right? They are actually cardiac myocytes, but they are kind of modified, right? With a few properties that are different. So these are conductive tissue in the heart, right? So the difference in them is that these produce what are called the pacemaker potentials. Alright? Now pacemaker potential is this. You see how it's different from what we call action potential, right? So this pacemaker potential, it makes sure that automaticity is present, right? So because of this automaticity, heart keeps pumping blood every time because there is electrical discharge at a regular rate. So now out of these, the SA node, AV node, bundle of his Purkinje fibers, usually we know that the SA node is the pacemaker. The reason that is because the SA node has the fastest rate, the more predominant, right? So it controls over everything else. In case the SA node was not there, next highest beat would be for AV node. In case the AV node was not there, next would be either the bundle of his or the Purkinje, right? And these are the ventricles. Got it? But their rate is very slow, as low as 20 beats per minute, right? So that is why SA node always predominates and becomes the dominant pacemaker in the heart. Now that you understood this, let's head on over to the drawing board so you can understand all these potentials better. Alright? Okay, so we had already discussed how in the conductive tissue and parts of a SA node, AV node, right, and all the bundle of his as well as the Purkinje fiber, we can develop what is called the pacemaker potential. And we know that it is automatic. And our goal right now is to understand why it has this property, why it is different from other action potentials which are there in the heart, right? So we'll come to it right now. We'll go to what is called the pacemaker potential, right? So over here, what happens is initially when there is depolarization, there is opening up of a calcium channel, right? So what you have to understand is compared to a normal depolarization current because of a sodium channel, that because of calcium channel is much slower compared to that of a sodium channel, right? So what happens is it won't be as fast as that you see in a normal nerve action potential. This will be much slower. So what happens is initially there is opening up of something called a T-type calcium channel, right? They are transient calcium channel. But what happens before that, we'll come to it later at the end of this repolarization. So okay, so what you can see over here is in the y-axis I'm using the scaling of millivolt and the x-axis would be time. So the resting membrane potential inside these pacemaker tissues, right, the conductive tissue, the resting membrane potential is not a constant value. It keeps undulating between minus 55 to minus 65 millivolt. Why, how, we'll come to that later, right? So in this stage, there is opening up of a T-type calcium channel, right? So what happens is, so what you see here is when calcium channels are opened up, obviously calcium is more in the extracellular fluid when compared to the intracellular fluid. So normally what would be the diffusion gradient from high concentration to low concentration? Because it is higher outside, it is obviously going to come inside the cell. When a positive charge comes inside the cell, what happens inside? It becomes less negative. So initially it was around minus 65 to minus 55 millivolt. Now that a positive charge has come inside, what is going to happen? It's going to become less negative. So it keeps going on top, right? So what it tries to do is it tries to go towards the equilibrium potential of that ion. and for calcium it comes to around plus 128 something, right? So it's trying to move towards that. So initially there is a transient calcium channels that are opening up. These are the P-type calcium channels, right? And once it reaches a threshold level around 40 millivolt, right? Now that is going to activate another set of calcium channels. These are what I call the L-type calcium channels. These are long acting, not transient like them, they are more long acting, right? So next step is opening up of the L-type of calcium channels. So again, there will be more number of calcium channels that are activated, and it will be slightly faster when compared to the T-type calcium channels, right? So it is again going to go on top. Alright, so what happened is there is a depolarizing current, right? How the depolarizing come, again we'll deal with that in a short while, right? So there is a depolarizing current. That depolarizing current will activate the T-type calcium channel, right? The same depolarizing current, once it reaches a threshold, is going to activate your L-type calcium channel. Alright, the same depolarizing current is going to activate another set of channels, which is a potassium channel, right? But the configuration changes that are needed to open up a potassium channel takes longer compared to that of a calcium or a sodium channel, right? So that is why always repolarization happens a little later. So the same depolarizing current which opened up the T-type calcium channel is also going to activate the potassium channels. But the conformational changes that are needed to open up that channel will take a little longer compared to that of these channels. So that is why that same depolarizing current will activate potassium channel. And slowly the L-type calcium channels also stop. They also start closing down. Alright, so it is said that around 100 to 150 millisecond of a time, the L-type calcium channel starts closing down. Right? So now what happened is at this point there is opening up of a potassium channel. So what is going to happen when you open up a potassium channel? Potassium is more inside or outside, in the intracellular fluid or the extracellular fluid. So if you look at the extracellular fluid, you know the normal value comes to 3.5 to 4.5 milliequivalent per liter, right? So that is the amount of potassium that is there outside. What about inside? It comes to around 140 milliequivalent per liter, right? So outside it is 3.5 to 4.5. Inside it is 140. So the gradient would be from inside to outside. So obviously when you open up a potassium channel, what is going to happen? Based on the gradient, potassium from inside is going to go outside. So what happens is a potassium efflux takes place, right? So when a potassium efflux takes place, when a positively charged ion goes outside of a cell, what happens to the inner ion gradient? What happens to it, right? So it was moving towards a positive, right? Because more positive ions were coming inside, the inside became more positive. Now when positive ions from inside are going out, inside becomes less positive, it becomes more negative. So it starts moving towards the negative, right? If I could put it in another way, the equilibrium potential of potassium is minus 90, right? So the equilibrium potential is minus 90 millivolt, right? So in any organism, any cell, whatever it is, they're always trying to reach an equilibrium. And when you open up a potassium channel, obviously that is also trying to reach its equilibrium. So it is trying to move towards its equilibrium potential, right? So its equilibrium potential is minus 90 millivolt. So it is going to try to move towards minus 90 millivolt. Okay, so there is a potassium efflux and it is going towards more negativity, right? So this is where things get interesting. So here there was a depolarizing current activating a channel, a depolarizing current activating a channel, and that depolarizing current activating another channel. So most often in our body, a depolarizing current opens up a channel, right? This is where, as I said earlier, things get little funny, right? And rightly so. These ion currents that are produced are called funny currents because these channels, there are a specific group of channels called the HCN channels, right? So these HCN channels, these open up to a hyperpolarizing current, not to a depolarizing current. So this is repolarizing, right? So during repolarization, it moves towards the hyperpolarization now, right? We know the resting membrane potential is minus 65, minus 55. So when it reaches hyperpolarization, what happens is it is going to activate another set of channel called the HCN channels. So most often in humans, in the heart, HCN4 is normally present, right? So when these HCN channels are activated, what is going to happen? These channels are permeable to both sodium and potassium, right? They are permeable to both sodium and potassium. So it won't, because they are like opposing, it won't outright lead to another depolarizing current, right? But because of influx of more sodium, right? And you also know the sodium potassium ATPase are also present, right? To maintain stuff, right? So because of the sodium, what happens is the HCN channels will result in the next depolarization wave, right? So automatically once it reaches hyperpolarization, it goes into the next depolarization wave, whereby it is going to now activate your T-type calcium channels, right? And after that again the L-type calcium channels, right? So it keeps going on in this manner, right? So there's a depolarization, repolarization, hyperpolarization activated cyclic nucleotide channels, right? And they will result in depolarization, and that will activate the T-type calcium channels, and again the L-type calcium channels, again repolarization because of potassium efflux. You understood what is happening over here? So that is why your heart is automatic, because of the presence of these pacemaker potentials, right? Okay, so now take a look at the nerve action potential. You see how different it is, right? So as I told you earlier, L-type calcium channels takes around 100 to 150 milliseconds to just close down, right? The whole action potential in a nerve muscle, right, that gets over in 2 to 5 milliseconds. You see the difference? That is what I said. Over there it is a sodium channel, over here it is a calcium channel, and that is the difference that you actually find over here. Alright, and the other difference is HCN channels, hyperpolarization, and this was termed funny currents because for the obvious reasons, right? Now we understood this. Okay, so now we understood what happens in a pacemaker set, right? What a pacemaker potential is and how different it is from the normal kind of potentials we see and why it is automatic, right? Now, once we understood that, we'll go on to what happens in the muscles. This is what is called the action potentials, which are generated because of these pacemaker potentials. So once the pacemaker potential, the depolarizing current in the pacemaker potential are traversing through the conductive fiber, right? What it does is it will result in depolarizing currents going through the muscle, and that spread will result in the next action potentials which are generated in the muscle, right? So the SA node discharges as it is going through the conductive fiber. The depolarizing current in the pacemaker potential will result in an action potential in the muscle. So that is the atria at first, that is followed by action potential generated in the ventricles, right? And because of this action potential, later the mechanical activity happens, right? So over here, the difference is the resting membrane potential for the action potential is minus 90 millivolt. Why is that? Why is it not undulating like that in pacemaker potential? Because there is no HCN channels over here, right? So there is a constant minus 90 millivolt, right, resting membrane potential over here. So at this point, what happens is there is the depolarizing current which is coming from the pacemaker potential. So this is going to activate sodium channels. So I had already mentioned the difference between a calcium and a sodium channel opening up. So if a sodium channel is opening up, you just think and tell me how is the action potential going to be. Is it going to be a rapid one or a very slow one? Right? Is it going to go like this or is it going to go like this? Right? So obviously it's going to go very fast because sodium channels are opened up right now. Right? And similarly, sodium is more in the extracellular fluid compared to the intracellular fluid. Right? In the intracellular fluid, it usually comes to around 14 milliequivalent per liter. In the extracellular fluid, comes to 144 milliequivalent per liter. Right? So when we open up a sodium channel, what is going to happen? Sodium, because of the diffusion gradient, is going to come inside the cell. Right? So when it comes inside the cell, it becomes more positive. The inside becomes more positive. Right? Also, the equilibrium potential of sodium is plus 64 millivolt. Right? So it's trying to move towards its equilibrium potential. Right? Okay. Okay. So we'll start with phase 0. So this is what is called the phase 0, where because of sodium influx there is start of depolarizing, right? So this is rapid depolarization, right? So at this point, around plus 20 millivolt or so, what happens is a potassium channel is going to open up and repolarization is going to start, right? But this repolarization is sort of different compared to what we see normally in nerve muscle preparations, right? So what happens is initially there is opening up of a transient outward potassium channel. So that will result in phase 1, which is a initial rapid repolarization, right? So these are transient outward potassium channels, and because of that repolarization happens. This is initial rapid repolarization, right? So now I don't need to explain anymore why it is going down. Already I mentioned to you what happens when potassium channels is opened up, right? So at this point, this is where things get different from a nerve action potential. Next, after this, in phase 2, what happens is, along with a potassium channel, there is opening up of a calcium channel as well. Now we know calcium is slow, right? So it lasts longer. Okay? And along with the potassium channel, there is a calcium channel. So calcium comes inside, potassium goes outside. So because they are kind of opposing the effect, what happens is it does not move much, right? It becomes sort of like a plateau because one is coming inside, calcium is coming inside, and potassium is going outside, right? So because of that, the potential does not change too much, right? And calcium is very slow, so it takes its own sweet time, right? So what happens is next. So this is phase 2. So this was phase 0, phase 1 and phase 2. So in phase 2 what happens is an L-type calcium channel is opened up, as well as there is a inverse rectifying potassium channel. So there was a transient output potassium channel opening up, now an inverse rectifying potential channel has opened up. Alright? Okay. So this will kind of prolong the action potential. Right? So why do we need this prolongation of action potential? because heart should be refractory for a long while. The refractory period of heart is longer. Why is that taking place? Because normally when the heart beats, right? Say when the heart beats normally, in between a sudden secondary impulse comes from somewhere, right? So if it was not like that, if this was like an action potential, what would have happened? Every other ectopic or secondary impulses that come from here and there is going to activate the heart, right? For that, just if you can't understand that, just take a look at the nerve action potential here, right? Let's compare that to this action potential. So this nerve action potential is very fast, right? In 1 millisecond, the depolarization happens, and in a total of 2 to 5 milliseconds, the whole thing is done, right? So that is all that there is time for absolute refractory period, beyond which if you give a secondary stimulus, the second action potential is going to happen within 2 to 5 milliseconds, right? But over here, what happens is up until this point, it is around 150 to 200 millisecond. You understand the difference? Over there it was 2 to 5 millisecond. Here it is 150 to 200 millisecond till this point, right? So that is the amount of period where it is completely refracted to the next stimulus, right? One thing. So that is why this calcium and potassium are opposing each other, resulting in a prolonged plateau, so that the refractory period of the heart is longer. Now the second thing, calcium influx is there, right? So in the heart, right, so when these potentials are generated, they go through the T tubules, right? So once they go into the T tubules, what happens is there's opening up of calcium channel. So opening up of calcium channels will result in calcium influx, right? So extracellular fluid calcium will come in, and this calcium will activate another set of channels, right, from the sarcoplasmic reticulum, right? So a calcium induced calcium release is there. So basically extracellular fluid calcium is needed, and based on that, intracellular source of calcium is also released. So ultimately all this calcium will go and start the excitation, contraction, coupling. So all that I'll do it in another series of lectures, right? So whatever is important for the ECG, that is all I'm concentrating on right now, right? So you get the picture, right? So now action potential is happening, right? Calcium as well as potassium channels are opened up, right? So at this point, at the end of phase 2, around 150 to 200 millisecond, what is going to happen is that calcium channels are going to close down, right? And along with the IKR, right, inverse rectifying potassium channel, there is also going to be opening up of another potassium channel, a slowly acting potassium channel. So now there is only potassium channel, no calcium. So there is a rapid repolarization. So this was the initial rapid repolarization. So this is the late rapid repolarization, right? Okay. So after the repolarization, it reaches the resting membrane potential, right? So that resting membrane potential, what we saw over here, that is phase 4, right? So phase 0 is a rapid depolarization. Phase 1 is the initial rapid repolarization. Phase 2 is the plateau phase. Phase 3 is the late rapid repolarization, and phase 4 is the resting membrane potential, right? And over here, just remember that there is a sodium potassium ATPase, right, as well as a sodium calcium exchanger, right? So these also later help maintaining this resting membrane potential, right? So just go back and try to think what happens in sodium potassium ATP, what happens in the sodium calcium exchanger, and how that is going to affect the ion chain. Because in case at some point some positive charge is going to come, think with respect to that what these channels do, right? Okay, so now we have understood this, right? So just take a look at this diagram from Ganong, right? So what you see here is various potentials that are there, right? So there is the SA node, there is the AV node, right? There is the atria, ventricle, right? And all other conducting tissues are also there, right? So if you look at the SA node, corresponding to that, you can see a pacemaker potential over there, right? You look at the AV node, again you can see a pacemaker potential over there. Now because of this potential in the SA node which is generated, that results in, yes, an action potential in the atria. Can you see that? Yes. And also because this pacemaker potential travels through the conductive tissue, right? It is now going to generate an action potential in the ventricle as well. So that, yes. So now, once we summate all these potentials, all these electrical potentials, you can see that the final waveform that we get is the ECG. You see that? Yes. So before we go on to ECG, there's one more thing you need to understand first. You need to understand how the normal conduction takes place in the heart, right? So once we're done with that, we'll go to ECG in the next episode. All right. So next, what we're going to try to understand is how the conduction system in the heart works, right? So if you can look over here, this is the right atrium, the left atrium, right ventricle, left ventricle. This is the superior vena cava, inferior vena cava, right? And what we have to understand is, right? Take a look at this diagram. There is a SA node, AV node, connecting bundles, bundle of his Purkinje fibers, right? So on top of this, there are these conductive elements which are present, these conductive tissues, right? So the major pacemaker is the SA node. So SA node is usually present in the superior posterior lateral wall of the atria, right atria, right? So superior lateral posterior wall of the right atria. So it will be just lateral to your superior vena cava. So we have the SA node over here, right? So then we have the AV node, atrioventricular, atrioventricular. So we have a AV node over here, right? Okay. So now first from the SA node, discharges are going to come, right? So they will be taken through many bundles, right? The Bachmann, Thorel, Wenckebach bundles, there are interatrial bundles, right? So these bundles are going to carry it all over to the AV node, right? Okay. So this is going to now go, it is going to activate the SA node, the atria, and it will be taken to the other side. Now what you have to understand is, apart from this action potential which are generated in the atrial muscle, so that is the action potential. This is the pacemaker potential which are generated here, right? So these potentials need to be taken to the ventricle. So there's no other passage through which they go. We know that atria and ventricle are separate syncytia, right? So once these pacemaker potential is generated here, there is no other way for them to reach the ventricle other than through the AV node, this bundle. Alright, so now they're going to activate all the muscles, right? I already told you there are gap junctions because of which the spread will be very fast, right? And because of the presence of desmosomes, they are going to contract together, right? Okay. And once they reach the AV node, what is going to happen is there is something called an AV nodal delay. That is because the AV node, they have lesser gap junctions, they are smaller fibers, and because of this, it takes a little more longer time for the impulses to pass through the AV node, right? So after that, they are going to penetrate into the muscle, right? So there are penetrating bundles which will go into the muscle, and from there they are going to form the bundle of His, right? And after the bundle, they are going to separate into two bundles, the left and the right bundle, and finally once they reach over here, they're going to form the Purkinje fibers. Right? So you see over there how the Purkinje fibers are going around like this. Right? So what happens here is, first there is the general direction would be like this towards the AV node. Got it? Right. So I told you about the delay in the AV node, and that is because you need time for the atria to contract properly before the ventricle starts contracting. Now, why is that? So for that you need to understand the cardiac cycle, right? So I'll be dealing with that also later. So I'll just brief you right now about the basics of it, right? So only if the atria contracts properly, fully, will enough blood be pumped into the ventricle, right? So once this gets depolarized, this is going to contract so that blood comes into the ventricle. Once enough blood comes into the ventricle, then there is proper ejection fraction, right? But in a scenario where this is not contracting fully, it is like partially contracted, and by then the impulses reach over here and this starts contracting, what is going to happen? Not all the blood from atria has reached the ventricle, and before that this will start contracting, right? So there won't be enough volume of blood, right? So the ejection fraction will decrease now, right? So to prevent that, we have a system like this where there is an AV nodal delay which makes sure that the atria is properly depolarized so that it can contract properly, and only then the ventricle can start contracting, right? Okay. So next, from here, what happens is the impulses, right? So these impulses will actually start activating the left side of the septum first. So it's going to activate the left side of the septum first. So the anterior left side of the septum, right? After that, it is going to slowly start activating from the left side to the right side. Right? So the left to right septal activation takes place. So the anterior parts of the septum gets activated. The left to right activation of the septum takes place. Right? And after that, it is going to start going towards the apex. Right? So now, what happens? These muscles in the anterior part, right? So these get depolarized. You got that? And it goes towards the apex. Alright? Okay. So it started off from SA node, went to the AV node. The anterior left part of the septum gets activated. Left to right septal activation takes place, and it goes towards the apex. Right? So what you have to understand is, in the heart, right, it is the endocardium which is first depolarized, and then it goes towards the epicardium. Right? So over here, this is the endocardium, this is the epicardium. So this is towards this direction, endocardium to epicardium. Right? So this is how it gets activated. Right? Okay. And the next thing is, once it reaches the apex, does the heart end here? Is there any part of the heart which is not seen here? Right? So that is what you have to understand. If you've done dissection and all that, you would understand that this is just a two-dimensional model of the heart. When you take it three-dimensionally, you know that there is a base of the heart which can't be seen here, which goes underneath. Right? So parts of the base and the pulmonary conus, right? And the superior part of the septum. So initially the anterior parts of the septum were activated, but there was the superior parts of the septum as well. So these parts, right, the base of the heart, the pulmonary conus, the superior parts of the septum, these are the last parts to be depolarized, right? So what happens next here is that once it reaches here, these impulses wind around and they need to go towards the base and the pulmonary conus. You got that? Right. So once everything is depolarized, right? So there'll be one period, right, when the entire heart and the entire ventricle is depolarized and refractile, right? So that point is there where everything is depolarized and refractile, right? Okay. So now if we were to think logically, there is a epicardium, there is an endocardium, right? The endocardium was the first one to get depolarized, right? Followed by the epicardium, right? So in a natural way, what happens would be that the repolarization also first starts from the endocardium, right? But that is not what happens over here. What happens here is, because the heart is contracting after depolarization, obviously the mechanical event is taking place. So when the mechanical event is taking place, the heart is contracted. When the mechanical systole is taking place, heart is contracted, the blood flow to the heart is less. In the contracted state, there is no blood. It receives blood in diastole, right? When blood flows less, what happens? The repolarization cannot take place normally, right? So instead, while repolarization, instead of starting from endocardium, it is going to start from epicardium, right? And the places which depolarized last will start repolarizing first, right? So just for you to understand again, there is a endocardium, there is a epicardium, right? So normally what happens is, from endocardium to epicardium, this is how normally depolarization takes place, right? So also when we consider it naturally, repolarization also should take place first in whatever depolarized first. But because the muscles get contracted and not enough blood flows there, repolarization is delayed here in the endocardium. So what happens now would be for epicardium to repolarize first. Okay, so when we try to make it out over here, this currents, right, the activation would be from epicardium to endocardium. So from epicardium to endocardium, right? So and from the base also is coming, right? So this is how the final repolarization takes place. So if I were to draw all these currents, it looks very confusing over here. I'll try to draw these currents again. So initially what happens is, from the SA node to the AV node, right? Atrial activation. This is how it happens. And after that, what happens is, the left part of the septum is activated. The left to right activation of the septum takes place, and then it goes towards the apex, and after that it climbs over down, right? Okay. And while repolarization is taking place, it is kind of the other way around. Understood? Right. So just keep this thing in your mind when we talk about ECG, once we're done with the leads and all that, in order to understand how the ECG waveform comes into being. This will help you out later, right? So that's it for today's episode. In the next episode, we'll go to ECG proper, right? So stay tuned in. Thank you.